Thank you very much to the organizers of WBAE for inviting me for delivering today's topic. So my topic is, are we still missing subtle RV dysfunction? Now, as you all know that why right ventricular assessment is still important, because it has got a significant impact on the long-term outcome of various diseases, and unless we pick up the early dysfunctions early, we'll miss the opportunity to pick up these RV problems and miss the opportunity to institute early treatment in these conditions, particularly in pulmonary arterial hypertension, tricuspid regurgitation, pulmonary thromboembolism and cardiomyopathies, where overt early dysfunction or early dysfunction what we measure by conventional methods may be too late to appear, and in these scenarios some newer diagnostic modalities with various forms of echo or other advanced imaging may be very essential to pick up this early and subtle RV dysfunction quickly to institute treatment and improve the prognosis of the patients also. But despite the clinical importance, investigations into the right ventricle have long been neglected, and with a disproportionate focus primarily on the right ventricle. Now, regarding the etiologies of RV dysfunction, the list is exhaustive, as we know, and primarily we can divide it into three main categories. RV dysfunction due to pressure overload, which can be due to certain causes causing acute pressure overloads like pulmonary embolism, ARDS, or mechanical ventilation. Some cases of chronic pressure overload in which pulmonary hypertension is possibly the commonest, and left ventricular disorders causing a chronic pulmonary arterial hypertension. Volume overload, acute volume overload in the form of excessive transfusion, or chronic volume overload in the forms of valvular regurgitations, pulmonary or tricuspid valve regurgitation. And in primary right ventricular diseases where the RV contractility is affected, like acute, where there is acute affection of the RV contraction like RV ischemia, myocarditis, sepsis, and in chronic conditions like cardiomyopathy, ARVDs, amyloidosis, sarcoidosis. Now, these are the common echocardiographic parameters that we are conversant about in our day-to-day practice, and we can measure majority of them using simple two-dimensional echocardiography. Right heart chamber dimensions, measuring the basal diameter, the right ventricular wall thickness, RVOT dimensions, particularly in conditions like ARVC, we all know. Right atrial major dimensions, minor dimensions of the right atrium, the end systolic area. These are all common measurements, can be picked up easily by 2D echo. Systolic functions can be measured by parameters like TAP-C, SRV, S prime, the pulsate tissue Doppler, or the myocardial performance index, or the fractional area changes. These are also common parameters that we can measure or usually measure while assessment of the RV function. The right ventricular diastolic function using tricuspid E by A, E by E prime, just like that of assessment of left ventricular diastolic dysfunction, though it is not as validated as that of the left ventricular assessment. And right heart hemodynamic measurement using simple IVC diameter, IVC collapse with a sniff, tricuspid regurgitation velocity, and measurement of pulmonary artery systolic pressure. So these are the common echocardiographic parameters that we all know that we can easily measure by using 2D or Doppler echocardiographic parameters. Among them, possibly RV fractional area change is one of the measures of RV contractility that can be easily measured, but we don't usually measure in majority of the cases. It is evaluated in the RV fourth chamber view. It requires a manual tracing of the endocardial area using RV area at the end systole and end diastole. And it is defined as the end diastolic area minus the end systolic area by the end diastolic area in the denominator, and it is expressed as a percentage. And usually the value less than 35% indicates an abnormal right ventricular contractility. So these are the common 2D and Doppler parameters that we can measure, which includes TAP-C, RV, S prime value, the 3D, in 3D echocardiography, the 3D assessment of the right ventricular ejection fraction, which is more precise than 2D assessment, which is difficult because of the unique geometry of the RV, the fractional area change, and GLS in certain cases. However, in certain scenario, the RV assessment might be difficult, where we have to resort to certain other, basic techniques, like in POCUS, in ICCU, a POCUS assessment or point of care ultrasound assessment of the RV may be necessary, because RV ICU patient, they cannot be mobilized. It may be difficult to obtain appropriate echo window. So this POCUS and transesophageal echocardiography are useful tools while assessment of RV function in this difficult scenario. Particularly in POCUS, it's not compatible with this format. Whatever. In POCUS, the thing is that we have to do a problem-oriented protocol for assessing specific problems, like for early detection of cardiac tamponade, so that we can institute treatment very early, or the need for comprehensive echocardiography or CT tomography, CT in certain patients. Abnormalities are typically described in a semi-quantitative or qualitative fashion, not in a very precise manner. Now, regarding transesophageal echo, it is useful for RV assessment in challenging scenarios particularly it has got an advantage when patient cannot be mobilized, patient is ventilated or intubated. It can assess the right atrial and RV size, global right ventricular function, tricuspid valve regurgitation, and the PA size. Also the IVC, superior vena cava size, with some degree of certainty. And evaluation of the right heart with TE, we can also get an idea regarding RV infarction, pulmonary embolism, existence of pericardial effusion, and any extracardiac mass effect on the RV, which can be easily picked up by a transesophageal echocardiography in an ICU setup. Now, regarding the advanced echocardiographic assessment of the RV, which includes the stress echocardiography, the speckle tracking, and the strain echocardiography, and in certain cases contrast echocardiography, that I will briefly discuss. Now, stress echo has got a potential to detect the cardiac dysfunction that usually cannot be detected by other modalities in resting condition. Just like the stress diastolic echo that we have discussed in the previous scenario, the stress RV echo can detect the RV contractile reserve that is present during stress, or stress-induced subtle or covert pulmonary hypertension, which can be unmasked in the early stages of pulmonary hypertension with this stress echocardiography.